All right, everybody. Welcome to the PSOP seminar for September 24th. One of the implications with COVID last spring was that several of our students that graduated from our program, whether it was a PhD or a master's degree, sort of got short shrift when it came to attendance at their dissertation defense or their capstone defense. And so one of the things that I wanted to do for them was this fall invite them to present at our seminar so that they could share their research with more of the faculty and students within the department and with the PharmD students that are interested in PSOP related work. So our first one of those speakers is Dr. Hari Patel. Dr. Patel is a two-time alum of the University of Illinois, Chicago. He graduated with his PharmD a few years ago, and then joined us for a fellowship, did a fellowship with us, and Takeda, I believe, was the sponsor of the fellowship at that time. Hari hung around and finished his PhD last spring. And today he currently is the principal of Immensity Consulting. And today he's going to talk to us about one of his dissertation papers, which, as you can see from his title slide, is a risk evaluation and prediction model that he developed. But in the chat, I'm going to give a plug for one of Hari's other papers, which he was interviewed on YouTube just 2 days ago, looking at the association between azithromycin versus amoxicillin in cardiovascular events. And so that's a 10-minute overview of his paper. You can also find his paper on JAMA Network Open. Without further ado, Hari, the floor is yours.
Great. Thanks, Todd. Thanks for the introduction there. So this is rather unusual. I mean, I'm used to giving the seminar. I think I've done a couple of times before in person, but I'll try my best to do this over WebEx. But keep it a little bit informal. If you have any questions, feel free to stop me. Again, so like Todd mentioned, this is part of my dissertation, which I presented back in March. It was literally 2 days before the quarantine measures took in effect. But yeah, I'll walk you through not the entire dissertation, but the parts, the one paper that I think stands out the most. So before I get started, slides are moving. There we go. I put this slide together just if it was to be in person, to kind of give you an idea, and I actually wanted to assess. I'm sure among everybody who's part of this WebEx, majority of you have taken azithromycin at some point in your life, or at least somebody, maybe a parent or somebody else that that was taking this. And really, back in 2012, there was a lot of news coverage related to this risk of cardiac events or fatal heart rhythms with azithromycin. And it was quite talked about heavily in the news media because of the sheer number of patients who receive azithromycin on a yearly basis. So really, from this idea that was first took place in 2012, it is where I started to look into it a little bit further and made it part of my dissertation. But for today's presentation, I'm going to give you a little bit of background in terms of what, just a little bit about azithromycin, what long QT prolongation is, some of the cardiac events that we measured in our study, walk you through the research gaps in terms of what was lacking, and then really focus on this comparison of azithromycin versus amoxicillin, and then provide you with a summary and then leave room for some questions at the end. So start out with this slide. There's over 40 million prescriptions of azithromycin that are dispensed in the United States every year. It is always going to end up in the top 10 drugs prescribed since its approval from the FDA. Azithromycin belongs to the therapeutic class called macrolide. The other cousins of azithromycin are erythromycin and clarithromycin. And again, it's been in the market for a while. Since I think it was first approved in 1991, and it really took off because of its short duration. Again, most antibiotics are used for 7, 10, or 14 days, whereas azithromycin was very effective in treating these infections in a short amount of time. Not going to go through the bacterial infections azithromycin treats individually, but just know it's a broad spectrum antibiotic. It treats a variety of indications, so not just upper respiratory, but other infections within the body. So it's a very, very effective treatment against bacterial infections. And then let me give you a little background about the QT syndrome. So some of you might have heard this in the past as far as how it's linked to cardiac arrhythmias and cardiac events. But in a nutshell, basically, if you were to measure the QT interval, what it represents on an EKG is the depolarization and repolarization of your ventricles. And in other words, it's the contraction and relaxation of your ventricles. And this measurement is important because a normal heartbeat is generated based on this rhythm. But anytime there's a prolongation in this interval and an ECG, that means it's considered to be prolonged. And that there's a different timing for men and women, 400 milliseconds for males and 480 seconds for females. But it's important because once you have this prolongation of QT interval, you're likely to experience tachycardia, fibrillation, and then there's this deathly event called torsades. So really, this consequences of having a QT prolongation is deadly. It may self-resolve at times, but in rare instances, it can lead to these severe consequences that I mentioned here. The one that I haven't described here is a cardiac arrest that could be an intermediate endpoint between QT long prolongation and death. Really, and again, we don't know what the incidence of this QT prolongation is in a normal population. Everybody would have to be hooked up to an ECG to kind of measure this, but often this is measured in hospital settings or patients who have pre-existing or congenital lung syndromes. But there's two main ways you can get this long QT syndrome. One is through, again, it could be presented when you're born, so part of your genetics, it's genetically present, or it could be linked to drugs. So in this case, what I'm going to be talking about is how it's linked to the drugs. And the way it does that is by disrupting the electrical current within your heart cells. So normally potassium and sodiums are moving in and out, but some of the drugs, such as azithromycin in this case, disrupt the flow of those currents, and the disruption is lead to changes in your heart rhythm, and hence the QT prolongation. So just keep in mind that's the pathophysiology behind why azithromycin has been linked to QT prolongation and cardiac events, is this disruption of electrical current within the heart cells. And then there are certain conditions which may put patients at a higher risk. These could be increased age or older age, females are at a higher risk, and then patients who have comorbid conditions. And of course, if you have existing electrolyte abnormalities, then you're going to be at a higher risk. So this is sort of the background in terms of what QT prolongation is, what are the consequences. But when patients present, let's say in a clinic or in the ER or at a hospital setting, the clinical presentation of these patients would be that they would experience palpitation, which is sudden rapid heartbeat, syncope, which is passing out, fainting, seizures, and bradycardia. So these are the typical clinical presentations of patients who are going through QT prolongation to ventricular tachycardia to fibrillation to torsades and even cardiac arrest. Here's a slide that just kind of shows the timeline of how azithromycin was sort of linked from an evidence perspective. So like I said, first it was approved in 1991. And for the longest time, azithromycin was considered to be the safest macrolide in terms of its potential to prolong the QT interval. And really early in 2000 is when we saw a bunch of case reports, about 10 to 15 case reports that linked the drug to having a prolonged QT interval or some of the cardiac events after patients were exposed. And really, it wasn't up until 2012 when there was a major publication in New England Journal of Medicine where a study showed that the patients who were treated with patients who were treated with azithromycin were more likely to experience cardiac events and cardiovascular deaths. Soon after this, the FDA issued a warning, and then since then there's been there's been multiple studies that examine the same question, but there's been a lot of uncertainty in terms of, the evidence that's been available, especially because some of the studies either confirmed the risk and some of the studies actually didn't find an increased risk. So but there's still uncertainty when I did the research in terms of the evidence that was available. And here's just I'm not going to go through individual studies, but these are the top 5 studies that were top 5 studies that were conducted from 2012 to 2017, observational cohort studies that looked at the risk of cardiac events with azithromycin, and then 3 out of 5 found there was a risk, and 2 studies, Swanstorm and Triforo, did not find there was an increased risk. And I'll bring this slide back together at the end in terms of what I think is our differences between what I've done versus what these studies have done. But I just want to give you an understanding that there's conflicting evidence in terms of if there is a risk with azithromycin or not. And then soon after the first study in 2012, FDA issued this warning, which was specifically focused on certain populations where azithromycin was thought to be increasing the risk. And really, the understanding was very vague, with the exception of patients who had cardiovascular events, which is what the study in 2012 found. But really, the FDA warning in a nutshell focused on patients who had prolongation of QT interval, existing condition, patients who had electrolyte abnormalities, patients who had history of torsades, bradycardia, or even heart failure, and then lastly, those who were especially taking QT prolonging medications such as antiarrhythmics. So in these patient populations, FDA say you need to use caution. Again, FDA was pretty clear the risk was rare, but let's be careful in this population is what was sort of the message from the FDA's warning in 2012. And really a lot of news media picked up this FDA warning, and there was a lot of coverage in terms of how this is a serious risk, even though it was a little bit of a rare risk. So based on the body of evidence that was available, when I looked at this question of azithromycin cardiac events, it wasn't clear if there is a risk, especially with the conflicting findings. There wasn't a clear understanding of who are the patients who would be at risk. And more particularly, we weren't sure if this risk was applicable in the general population. So the previous studies that I've showed looked at either the VA or Tennessee Medicaid population, very, very specific populations, but those normal individuals between the age of 18 to 36 or 18 to 45 weren't included in these types of studies, and they tend to be more sicker populations that were evaluated. Also, there was not a whole lot of emphasis in terms of are the patients taking QT prolonging medications at a higher risk, or what is the risk among patients who are prescribed medications along with azithromycin that prolong the QT interval. Also, it was unclear that the subgroups that were included in FDA warning are in fact at a higher risk. The basic understanding of those patient population FDA warning came from a general understanding of what puts patients at a high risk of cardiac, high risk of having QT prolongation. But really, these groups, if they were at a higher risk when treated with azithromycin, wasn't evaluated. And lastly, the warning that did have any impact. This was looking at, if the people believe the evidence and if the people believe the warning, was there a change in the way azithromycin was prescribed before and after the warning? So there was limited body of evidence in looking at that. So I'm not going to go through all of my specific aims, but what I'm going to focus on is the third aim. But it just give you a little bit of background in this specific aim number 1 and 2. The first one was looking at the change in the prevalence of cardiac risk factors among patients who receive azithromycin before and after the FDA's warning. We really wanted to see if there was a concern with the populations that were mentioned in the FDA warning, then we would have seen a decline after the FDA warning among patients who receive azithromycin. But what we found was, in fact, that there was no change. 1 in 5 patients who received azithromycin had a cardiac event, cardiac risk factor before and after the warning. So really, not a whole lot of prescribing that was changed as a result of this warning that was issued by the FDA. And then in specific aim, we looked at risk prediction model, and we want to look at patients who are prescribed azithromycin and what were the baseline characteristics, especially conditions and specific QT prolonging medications, which put patients at a higher risk of experiencing cardiac events. So we developed a cardiac risk predictor model, it's built a risk calculator, which gives you a score to help you understand what the risk of the cardiac events would be among patients who are treated with azithromycin. And then lastly, in the third paper, which was the risk evaluation study, we compared the risk of cardiac events among patients who were treated with azithromycin versus amoxicillin, and which I'll go into more detail about today. But just want to give you this were the three specific aims for the dissertation. So this third paper was just recently published in JAMA Open Network. You can find the full study there, but I'll walk you through the results. So instead of having a whole lot of text, I like to show a lot of visuals, so hopefully that's okay. But so this was a retrospective cohort study. We used market scan Truven database, which included de-identified data of healthcare encounters over millions of patients who are commercially insured from the United States. And our study period for this analysis was from 2009 to 2015. And our eligibility of the patients who would be included in the study was from 2010 to 2015. And really, the date of patients receiving azithromycin or amoxicillin, we classify this as the index date. One thing I want to point out here is that the risk of cardiac events with azithromycin it is acute, it's transient. And so let's say if you were exposed to a medication today, and if you survive the event, and let's say if you are re-exposed to the medication 3 months later, then you're still at the same risk of experiencing that event. Your risk doesn't change, and this is why instead of using a fully new user design, what we've done is we've taken episodes seeing patients who were treated with either one of these therapies after a pre-specified period. We're including both of their exposures as an episode. And really, the only washout period we applied was that patients couldn't have been exposed to either one of these therapies in the 30 days prior to the index date. And then we also didn't want to look at the maintenance use of these medications. So azithromycin maybe perhaps among COPD patients, there are other conditions in which it might be used as a maintenance therapy. What we're interested in is patients who are prescribed azithromycin on a short-term basis, 3 to 5 day period for acute bacterial infections. Are they at a higher risk of cardiac events? And the reason why we use amoxicillin is, again, it's a great control because it hasn't been associated with any increase in QT prolongation or any cardiac events. And it is interchangeable in terms of treating those bacterial infections. It's a great control that we've used, and majority of the studies that looked at this exact question in the past have used as well. Really, we were very, very general with our inclusion criteria. Really, patients had to be enrolled in the study for 12 months. And this is a differentiating factor in terms of what we've done versus previous studies. Previous studies had excluded patients based on age, certain conditions. There were other factors that influenced that, but we wanted to be more comprehensive and inclusive of all the patients who would have been treated. So we weren't restricted in terms of age or any conditions. Here, really, the continuous enrollment within the 12 months in the baseline period was the only criteria we applied here. Okay. Next, let me talk about the study measures. So at the index date, so the date of patients receiving either azithromycin or amoxicillin, we measure patients' age, gender, region, and type of insurance. Within the 90 days prior to the index date is when we measure the concurrent use of QT prolonging medications. And the way we did this is by looking at the day supply. And we allowed for a 15% gap in those day supplies and seeing if there was an overlap of those day supplies with index therapy. And we classified those medications as QT prolonging medication. And the medications we use for this QT prolonging come from, I think some of you might be familiar with this database if you're a pharmacist practicing. It's called crediblемeds.org, which puts a comprehensive list of over 200 medications that have been either associated or are known to cause QT prolongation. So we used over 200 medications to measure our list of QT prolonging medications here. Next, we measure comorbid conditions, which were in the baseline period, so at any point in the 12 months. And then the way we did this was using AHRQ's clinical classification software. Some of the students might be familiar with this, but it's a great software that classifies different conditions into different categories and gives you just an overall nice view of the clinical conditions. And there are over 17,000 conditions, but they're bucketed into level 1, level 2, and level 3. We ended up going to level 2, which is a subcategory of the general condition. So it gives you a little bit more clinical granularity in types of conditions the patients had in the 12 months prior to the index date. And then in terms of our outcome measure, we looked at the 5, 10, and the 30-day period, and we classified cardiac events as having patients who had a primary diagnosis for a hospitalization or an emergency department visit based on the ICD-9 codes. Again, ICD-10s weren't available at that point. This is a study period of 2009 to 2015, so we relied on ICD-9 codes. And then the algorithm, or the codes that we use have been previously validated to have a positive predictive value of 80%. And this included conditions such as syncope, palpitations, QT long prolongation, tachycardic fibrillations, cardiac arrest, and death. One thing I'll mention is that claims databases are not necessarily the best measuring death. So it's one of the biggest limitations of this study, which I'll go over towards the end of the slides. But we tried to see if patients have been hospitalized or if their diagnosis was death at the time of admission. And we were able to identify a couple that they had that diagnosis be included. But the major focus of this research question is when looking at the cardiac events, not death. Okay, so in terms of statistical analysis, before I get into it, just going to give you a little bit of an overview. So, like I said, azithromycin is prescribed very routinely. So between the point of 2009 to 2015, we had over 44 million patients who were prescribed either azithromycin or amoxicillin. This was a very large cohort, and for really purpose of it being efficient, we looked at the random sample, which was 25% of that 44 million, in order to generate our propensity score. And what we used here was high dimensional propensity score to control for unmeasured confounding. And there's a big issue with confounding by indication here, especially the severity of infection is likely to be associated with cardiac events. So we rely on a more robust method. And again, the way this is done is that empirically looks at 500 covariates in the baseline period. So this could be including inpatient diagnosis, outpatient diagnosis, procedures from both inpatient and outpatient, any drug use. And then we also predefined some of the variables that were thrown into the propensity score model. And then based on this propensity score, we generated, using logistic regression, we generated a propensity score. Again, it's the probability of patients receiving azithromycin and amoxicillin based on these covariates. After generating the propensity score, we matched amoxicillin patients with azithromycin. It was a 1-to-1 matching with a 0.2 standard deviation of CAL4-WIT. And we used the nearest neighbor approach to match these patients. And then the way we evaluated if there were differences in these patient populations, basically between amoxicillin and azithromycin, is that we looked at the standardized difference. Anything greater than 10% in those characteristics is what we consider to be significant in terms of the characteristics between those two populations. And then we used the propensity score to generate a conditional logistic regression model, and we generated an odds ratio with 95% confidence interval. And then we looked at several subgroups, and these subgroups were pre-specified based on the understanding from the previous literature. And then we also performed a few sensitivity analysis to make sure our overall findings were robust. In terms of the subgroups, we looked at patients who were over the age of 65, and then we looked at predictors that we had identified in our previous model. And again, some of the predefined variables were also including what we found from our prediction model from AIM-2. And I'll go over what these specific two sets of predictors are and when I show you the results, but we included a subgroup patients who had those predictors. We looked at the overall population who had cardiovascular disease, and then we focused on patients who were using QT prolonging medication concurrently with either azithromycin or amoxicillin. So these were the subgroups we looked at. In terms of sensitivity analysis, like I said, there's some people agree with using the method of looking at episodes, which is what previous studies had done, and some people prefer to use user design. Again, to alleviate this concern, we restrict our analysis just to unique patients. So this is mimicking like a new user design patient being treated for either one of these therapies for the first time. We focused the analysis on there to see if there was a change in our baseline results. We also looked at if there was an impact before and after the FDA warning. Again, we found from our paper one that there was very little impact in terms of cardiac risk factors among patients who were prescribed azithromycin, but we also didn't want to rule out a risk validation study. So we looked at the subgroup, or we looked at the sensitivity analysis, focusing on patients who were prescribed before and after, so there was a change in the estimate. And then lastly, one thing I didn't mention in my previous slide was that we measured the claims that were, let me just go back. So when we measured the cardiac events, we measured the things that were originating, we measured the things that were listed as primary diagnosis for hospitalizations and ER visits. But there's another way to take a look at this, which was there could be events that are originating in outpatient settings, which could lead to a hospitalization a little bit later on. And there was a really nice paper that one of the previous studies that I showed had included was that you could measure these events. And again, it's the idea of getting the timing right. So, things that could be originating in outpatient leading to ER visits, we did use a method to include that. Again, in order to make sure our assumptions were correct for that, we focused our analysis just on using inpatient claims only to see if there was a change in the baseline results. So in terms of the propensity scores, here's what the distribution looks like before and after matching. And below are the numbers. So out of 44 million, we took a sample of 25%. So we had about 9 million patients 9 million episodes of azithromycin and amoxicillin. And then after applying propensity score 1-to-1 matching, we left with a cohort of 2 million each in azithromycin and amoxicillin. So it's a fairly large cohort, and the propensity scores overlap pretty well. So I have a bunch of variables that I measured in this study. Like I said, there's quite a few conditions, but what I'm going to focus on in the next set of slides is the overall results and overall findings. So what I'm presenting here is just baseline characteristics and clinical conditions between amoxicillin and azithromycin users. These are propensity score match episodes that we're including here. And instead of including p-values, which probably would be significant given the large number of patients here, what we relied on was a standardized difference. Like I said, anything greater than 10% in these characteristics would be considered not being balanced. And as you can see here, this just, again, top overall clinical and demographics variables I'm included, but we had a lot more which were all balanced. Well, the only exception was PPO insurance type. I think patient. So the standardized difference for PPO was about 0.1, exactly at 10%. And patients who were receiving azithromycin were more likely to be in that category compared to amoxicillin. And we didn't think that was a concern because we didn't believe it was related to any. It was related to any cardiac events. I think it was just a matter of patients getting that medication. But overall, our group, again, we're very, very general in terms of the group, the age group here. So we do have quite a few patients who were over the age of 65, but also patients who have 30% of the patients were less than 17 years old. On an average, the age was about 36 years old. Half of these patients were females. And in terms of the clinical conditions, really, there were no differences between both of these cohorts. But as you can see, about 20% of the patients had hypertension. To point out, so the distribution, again, is the same between both of these cohorts. And then a lot of these patients had respiratory infections, which were probably coming within the first 5 to 10 days before the index date. So the condition for which these drugs are prescribed. And then about 6 to 7% of the patients had COPD. So really no differences in terms of clinical or demographic characteristics between both of these cohorts. Here's a slide showing you the breakdown of QT prolonging medication by each cohort. Again, the same format as the previous one. We had over 20% of the patients in each group that received at least one or more QT prolonging medication, and about 6% or more received two or more QT prolonging medication. Again, we include a listing that had about 200 medications, but here are some top-line therapeutic areas that we want to highlight. Majority of the patients had, an antidepressant, which is falling into the classic category of QT prolonging medication. And again, this is just not that the patients were more likely to take antidepressants, it's just the patients, not patients, the list of medications for QT prolonging drugs includes a lot of antidepressants. So about 7% in each cohort is what we measured here. The other drugs of interest would be antiarrhythmics, very, very low, about 0.3% and 0.2% is what we saw between amoxicillin and azithromycin. Okay, so in terms of the occurrence of cardiac events, here's a breakdown between 5, 10, and 30 days. And the results for our base case, we were focusing on the five-day period. And this is what's consistent with previous studies that found an increased risk, which was within the 5 days. What we see here is majority of the patients had either syncope or palpitation as their primary diagnosis. It's rare to see patients having cardiac arrest, cardiac arrhythmias, as they're shown here, majority of them. But what's important to mention here is that, these events may seem nonspecific, but they were serious enough that led to a hospitalization and ER visit. So again, they're very important in the cascade of what happens to the patients who would experience torsade eventually and cardiac death or cardiac arrest, that these events are measured and included. So majority of the patients, again, had syncope and palpitation as their primary event. We saw the same frequency in the 10 and the 30 day. The overall occurrence of cardiac events as an overall category was 0.03% at 5 days, 0.05% at 10, and then 0.1% at 30 days. So it's just very rare that these patients experience cardiac events. So 0.03 translates to about 3 to 4 events per 10,000 patients who are treated with azithromycin or amoxicillin. So what do we find here? Well, here are the overall results. What we found at 5, 10, and 30 days, there is no increased risk of cardiac events when you're comparing azithromycin versus amoxicillin. Again, the reference group here is amoxicillin. No change. No increased risk. We're fine. The odds ratios are crossing the interval of 1, and this is further breakdown by the subgroups we looked at. Again, we looked at about 5 different subgroups, and here's a list of here's a list of predictors that we included for Model 1 and Model 2. But out of all the subgroups, the only difference we found was among patients who were co-prescribed a QT prolonging medication with azithromycin, that were at about a 40% increased risk of experiencing a cardiac event compared to patients who were prescribed amoxicillin and another QT prolonging medication. And from our risk prediction model, again, I know I didn't show the paper, but these are the predictors that we identified, which were focused on certain cardiac conditions, which put patients at a higher risk, and also the presence of QT prolonging medication for Model 1. And then Model 2, we focused on the demographics and the specific classes of QT prolonging medications which were identified to be putting patients at a higher risk with azithromycin. And when we looked at both of those, there was a trend in an increased risk, but these were not really significant. Again, we saw the same thing with patients who had a pre-existing cardiovascular disease. It's a wider estimate because we had a smaller sample of patients who had cardiovascular disease. I think it was 100,000 patients. It seems large, but the confidence interval was much wider, trending towards, I'm not trying, it's the odds ratio is 2, but not really significant. And this is what the previous studies identified, that patients who had pre-existing cardiovascular disease, they were actually at a high risk of experiencing cardiac events when treated with azithromycin compared to other antibiotics, and we didn't confirm that finding in our analysis. In terms of the sensitivity analysis we've done here, here's the breakdown in terms of patients who had repeated exposure. So these patients had multiple episodes of azithromycin or amoxicillin therapy. We looked at patients who were unique. These are the new, mimicking the new user design. We looked at before and after the FDA warning, and the outcome where it was only measured from inpatient claims. Again, no difference in any of these sensitivity analysis results. We do see quite a wide interval. Again, a lot of the patients who were included in the analysis were sort of falling into this bucket of unique patients. They only had one exposure. There were only few that had repeated exposures. So in summary, the overall risk of cardiac events was very small, 0.03, which translates to about 3 to 4 per 10,000. What we found was there was no overall there was no increase in the overall population when you're comparing azithromycin versus amoxicillin. And in the subgroups, we did see some trends, but really nothing significant. The only difference we found here was that patients who are taking concurrent QT prolonging medication, again, within the 5 days, there is an increased risk with azithromycin compared to amoxicillin in those who are prescribed QT prolonging medication. So this was our overall takeaway from this study. In terms of our limitation, it's a retrospective observational study, so it's prone to unmeasured confounding. We tried a high dimensional propensity score, and proxy could control for some of these unmeasured confounders, but we don't know to what extent. So it is one of the limitations. There could be potential measurement errors in this analysis as well. And speaking of these unmeasured confounders, so for things along the lines of race, smoking status, over-the-counter, especially pseudoephedrine, which is known medication to prolong the QT interval, could be used for respiratory infection when people have cold and whatnot. Shouldn't be taking it, but you see patients taking that. That could potentially influence the results what we see here. We didn't measure electrolyte abnormalities. Again, these was on an outpatient basis, so we not only we didn't have access to it, but we just couldn't get to it because both of these drugs were prescribed on an outpatient basis. We don't know if patients had any increases in their QT interval, and then also we didn't have the body mass index, so no weight. And these are the things that could have potentially influenced our results, but we didn't have access to it. But again, with the high dimensional propensity score that we use, feel fairly comfortable and making sure that we feel fairly comfortable that these things would have, in theory, been equal between both of the cohorts that we compared. And lastly, I kind of mentioned this point earlier on, but claims databases are not great for measuring cardiac deaths. Again, we don't have a good idea of when these deaths would have taken place. Usually in a claims database, they're measured at the end of the month. And the ones that are measured are really hard to get to, even if you're looking at ER visits or ER claims or whatnot. But the context of this, the study results should be only in terms of cardiac events and not cardiac deaths, which is what some of the other previous studies had measured. So, I put this slide together and just to translate what does this mean for researchers. I think there's definitely more work needed to measure if there is an increased risk of cardiac deaths with azithromycin. And in terms of providers, especially pharmacists, who are more likely to see the different types of medications that patients would be on, I think it's important that these pharmacists counsel patients about the potential drug-drug interaction, especially if patients are experiencing non-specific symptoms, to consider changing the therapy if they had pre-existing conditions or if they're experiencing such conditions with azithromycin. And then lastly, prescribers where azithromycin is probably originated. I think we need to be careful in terms of how prescribers are using these medication. Again, the risk is small, but nonetheless, this is a risk that we could avoid, especially when you have other options such as amoxicillin. So just keep in mind that, in terms of different aspects, in terms of what's applicable to researchers versus pharmacists versus prescribers here. I'm actually going to skip this slide. I kind of talked about what we found from AIM-1, AIM-2, and then again, I've already went through the detailed study in terms of what we looked at AIM-3. But I did want to bring this back together in terms of how does it fit in the current body of evidence that evaluated cardiac events and cardiac deaths with azithromycin. So now we have 3 studies that found a risk, 3 studies that did not, including ours that did not. What's important to look at is the types of populations that were included. Again, the very, very specific populations that were included in the earlier studies. And they did a pretty good job in measuring, the cardiac deaths compared to our study, which looked at cardiac events primarily. Our closest study that we can apply our findings to is this one that was done in 2007, which combined 7 different countries from Europe and looked at a case control of patients who would be patients who were treated with azithromycin and had cardiac events. Very similar approach, with the exception ours was a retrospective cohort study. Theirs was a case control study, and then they did adjust for QT prolonging medication, but they did not look at the subgroup of patients who were prescribed QT prolonging medication. So overall, I think there is still a lot of uncertainty, but one thing that's clear from all of these studies is the risk is rare, and perhaps the patients who are taking these medications concurrently with QT prolonging is where we need to be careful. Lastly, I'd like to thank my committee members and just one person I needed to change on that. I don't know if Glenn joined, but that was for him. So committee members were great in providing clinical input. I really couldn't have done this study without them. And then I'll thank 3 individuals, Alam, who helped me with high dimension propensity score coding, Nadia, who shared her prediction model codes and helped me with that. And then lastly, Yash, for just, emotional support at some point along the way while I was doing my PhD. So I'd like to thank those 3 individuals. And here are my references. I'll go to any specific questions you have.
Awesome. Thank you, Hari. What questions do you all have for Hari? Feel free to either drop them in the chat box or unmute yourself and ask away.
Hey, Hari, this is Carter. I have a question for you about your actual risk window that you're prescribing to azithromycin. So you assume that basically the risk is based on the index date of when they're prescribed. But I was just wondering, was any thought about, because someone could have gonorrhea and get 1 gram of azithromycin prescribed to them on one day. Someone could have a Z-Pack and that could be spread out, for multiple days. So would that risk window possibly be, based on the last day that they were taking it versus just index, or what your thoughts were around that? Yeah,
so I did look at, the day supplies and the milligrams of azithromycin that were prescribed. I think 98% of the patients had it for a 5-day traditional period. I think there were a few that had it for a 10-day period, but it was very, very rare to see. I think maybe just a handful of patients might have gotten it for 1 gram. So in terms of the timing based on that, it's the risk that's there from 3 to 5 days. And I think comes down to patients receiving the 500 milligrams on the first day and then 250 on the subsequent day. So you're dosing higher on the first day, and then it gets lower on the 3, 4, 5 day period. So on the 5-day period is what we saw the risk being present in the previous study, and based off of that's what we used. But yeah, you're right. Maybe the risk could be just present in 1 day, could be just present within the first or just the second day. But what we used here was just that 5-day period. We didn't look at it on a daily basis.
Gotcha. Thank you.
Mm-hmm.
Are there other questions for Hari?
This is Surrey Walton, one for you, Hari. Remind me, is there mortality at all in the Truven data set? I know you couldn't look at cardiovascular specific, but is there mortality in general? Did you look at it?
So from 2009 to 2015, I would say probably not. I know Truven has been working to, get the mortality data linked to these claims, but the data that I used, the only thing you can pick up is there were a couple of codes in the ER claims, inpatient claims, which were designated for patient arrival on death or patient. I think I forgot the second one, but yeah, there were a couple of codes, but really it's not great for measuring mortality. I don't think I would suggest it for any future research.
Yeah, thanks. It's interesting in the literature that there's findings for cardiovascular death, but not for events. So I just asked for that reason. But great presentations. Good to see you.
Yeah, thanks. And yeah,
Hari, do you have any speculation on that, on deaths versus events?
I can't say about deaths. I think we still need to look at maybe future studies focus on death. But what's important is these cardiac events that are sort of intermediate points between patients receiving the drug and, let's say, the ultimate outcome being death, that these patients are experiencing this intermediate event. These events could be transient, sometimes self-resolving, but since they were serious enough that led to hospitalization, I think relying on cardiac events is, I guess, robustimized. But again, there's more work needed in terms of looking at cardiac deaths like the previous studies I've done. But again, the other point would be that the events of cardiac deaths would be very rare as well. And this is what we saw in the previous studies as well. It was actually much more rare than the prevalence of cardiac events.
Yeah, as you were presenting that last slide that summarized the studies, I had the same thought that Suri did about what's happening here with cardiovascular death. And it made me wish that you would have calculated how many additional deaths would have to happen in your data to see that kind of magnitude of risk. But you know what? You published the paper already, so never mind.
Yeah. No, so
do you want to say, Hari? I'm sorry. Go ahead.
No, I mean, we calculated the expected number of events based on previous study, and it was in line with, what we saw in previous. But yeah, in terms of cardiac deaths, we could have, you're right, we could have calculated the expected number of deaths. But again, since we can't measure it, I don't know how much else I would have been able to do.
No, I just think we could have calculated how many more deaths in the azithromycin group we would have need to have seen to see that magnitude of a risk, in this kind of age population. I think it would have really been a lot of deaths that would have necessitated an effect estimate that high. You want to say anything about sort of the current state of azithromycin and COVID-19? I mean, this is really one of the reasons I think why your paper has gotten a lot of attention. You've hit this sweet spot in terms of interest in this drug and its use in COVID-19, potentially even in combinations with other treatments.
Yeah, no, absolutely. So, while I was preparing for that interview, one of the things I found was that azithromycin is the second most studied drug for COVID, right after hydroxychloroquine. And there's studies that looked at it in combination, especially. And for those of you who don't know, hydroxychloroquine and chloroquine are both QT prolonging medication. So really, I think the reason why this paper is probably gaining attention is that when patients are treated with both of those drugs in combination, they are at an increased risk. And what we found was, I think there was a randomized control trial from Brazil that showed, in fact, it was stopped because there was an issue with patients experiencing these cardiac events. The most recent trial from the same group looked at use of azithromycin with and without hydroxychloroquine, and it didn't find any efficacy benefits. Again, the risk has been studied significantly in inpatient populations, so it's definitely of concern when these medications are prescribed together. I think the risk is even going to be greater when they're used as prophylactic medications among patients who might receive them on an outpatient basis. So there's studies that are examining that, saying healthcare workers, especially, they're given hydroxychloroquine and azithromycin, are they less likely to experience have COVID deaths. And I think that's going to be concerning when patients are using both of those drugs together.
All right. Thank you, Hari. Great work. It's hard to virtually acknowledge the great presentation you gave us, so I'll just do it for everybody. So thank you for joining us today, and thanks for presenting your work. It's great to hear it. Thanks everybody. We'll see you next week.